Carolina Family Health Centers is a network of 3 federally qualified community health centers out of Nash, Edgecombe, and Wilson counties. Among a number of our services we provide, we're also a Ryan White Part C and B grantee. We have 19,000 total registered patients, but 425 of those are HIV positive. My project mentor, who could not be here today, she's seeing our Ryan White patients, is Karina Bizard. She's also our Ryan White project director. So being a pharmacist, taking medication is very important to me. And with most disease states, you don't take your medication, you don't typically get better. And that's very true and very important with HIV. So that's kind of what spawned my interest in this project. And I kind of wanted to see how well Carolina Family Health Centers was doing in terms of a success rate. How many of our patients who were actually on HIV medications were achieving an undetectable viral load. Up until March of this year, we did not have electronic health records, but we were using the CareWare software system. And so these are very rough statistics, but we were on about a 62% success rate. So 62% of our patients who are actually on medication were actually achieving an undetectable viral load. And I am also the clinical pharmacist that works with our Ryan White team. And I had a patient that failed her medication regimen. It was a once-a-day pill, so we got her down to as best of a regimen in terms of adherence purposes. She failed that regimen. The reason she told me she failed that regimen is she thought the pharmacy was going to call her when she needed refills. And so that just kind of impressed upon me. You think patients know how to take medications, but do they really? And it wasn't that we weren't or didn't have any efforts to enhance adherence to medication. As you can see with our current services under the Ryan White grant, we are able to do quite a bit. You know, some of my time is spent over in the clinic. We have behavioral health, we have a peer counselor, outreach, and education services. So my program, or my project rather, was 2 efforts. One was to develop a patient assessment tool to attempt to try to bring out some barriers to patients taking their medication, and then to provide some specific follow-up services to those patients enrolled in the program. Call the patients back after a month of taking medications and make sure they've got a follow-up visit and make sure they're not having any problems with their medications. So the questionnaire was utilized to determine each patient's ability to take and manage his or her own medications. And we assessed 5 different areas that could be potential barriers. Mental health and substance use are fairly obvious why those were included in the questionnaire. Environmental factors such as current housing status, whether or not a patient has a refrigerator at home is an important consideration. Cognitive abilities went through actually handing a patient a pill bottle. Can you identify the prescription number, how many refills, and where to call the pharmacy back? And then an attitudinal assessment specific to HIV. Do you believe you have HIV? Do you believe that HIV is what causes AIDS and can potentially cause you to be sick? And in each of those areas, that questionnaire, the patient was either rated positive or negative readiness to the treatment. I administered the questionnaire, and patients were selected by their provider, referred to me during normal kind of clinic operations. And it's kind of important to note for what we're going to move forward with is that the patient already had received a prescription for their antiretroviral medications, and they knew that they were going to get started. So if a patient rated negative in any parts of those pieces of the questionnaire, that did trigger a referral to one of our in-house or on-site services. Mental health and substance use, we have an on-site licensed clinical social worker. Environmental, we did have one patient that did not have a refrigerator, did not affect his HIV medication, but he was on insulin, so we were able to get him some a little better stable housing with refrigerator access. And with mental health, I'll go back, and mental health and substance use, that was 5 referrals for the project. Cognitive abilities, the plan was, we didn't have any patients that rated negative in this area, but the plan was for the pharmacist to go over how you call in a refill to a pharmacy and how that works, and then attitudinal assessment was going to either be with the clinical social worker, peer counselor, or medical provider. So I did follow some clinical markers during the course of this project. CD4 count and viral load. Viral load being most important because that's going to tell you whether or not the medication works and whether or not the patient's taking their medication. And because of how HIV medication works in the disease state, I did follow it 3 months after treatment started. And any patients that were seen longer than 3 months, I did follow those values up to the most recent to make sure that the patient had remained successful. I was able to assess since January 2012, 13 treatment-naive patients new to medication. And the average CD4 count upon assessment was 376, and average viral load was 333,000. And 10 of the 13 patients, I could assess at least 3 months past questionnaire. 3 of those, 1 transferred care to another medical facility, 1 patient was lost to follow-up, and 1 was recently assessed within the last 3 months, so I don't have lab values for those. But post-assessment, our average CD4 count went up to 573, which is a 52% increase, and average viral load went to 5,606, which is a 98% decrease in viral load. Our most successful patient went from a viral load of 2.2 million to 169, I believe, so that was huge. So the successes of the program, lessons learned, is our success rate was 8 out of 10 patients assessed did achieve an undetectable viral load, which was huge. So I'm calling the project a success, over 62%. And of course, during the last 2 years and during this project, there was certainly enhanced collaboration among our brown-white team and just talking about the concept of treatment adherence. Some opportunities for improvement is we only talk to treatment-naive patients. I think we can certainly go to patients that have failed regimens, and I think they're probably a little more important to assess, but we wanted to keep it simple at first. I was the only person that was involved in the questionnaire, and I think we need to expand that because I was the rate-limiting step. And it was a very lengthy questionnaire, so we were looking at ways to kind of trim that back if possible. It was on average 30 minutes. And I had a patient that was a candidate for the questionnaire, but he had irretractable hiccups and could not make it through the 30 minutes of the questionnaire. So my next steps, I am going to share these results with, of course, our team at Carolina Family Health Centers, and as well as the Pharmacy Directors Group at the North Carolina Community Health Center Association. I think more disciplines other than just pharmacy can administer this questionnaire. And like I said before, want to expand this intervention to include patients who not only are naive, but who have failed 1 or more multiple regimens. And schedule a separate appointment for this questionnaire because our patients get overwhelmed when they have too